So, dear doctors, this is also very important topic: skin and diabetes mellitus. Okay, the cutaneous markers of the diabetes, skin problems due to complications of the diabetes, skin problems due to complications of the diabetic treatment, skin lesions associated with the endocrinopathies and other syndromes. So, in that way, skin will be involved in the diabetes. It helps you as a diagnostic markers to know whether the patient is having insulin resistance or not, like acanthosis nigricans or the skin tags. So these are all the cutaneous markers. These are the markers: necrobiosis lipoidica diabeticorum, granuloma annulare, diabetic dermopathy, shin spots, diabetic thick skin, including diabetic hand syndrome, acanthosis nigricans and the skin tags, and diabetic bullae. So whenever you see these things, these are the markers of the diabetes. So mostly we see for the acanthosis nigricans the skin tags on the nape of the neck, a velvety appearance to know whether the fellow is having insulin resistance or not. So not only that acanthosis nigricans the skin tags, you please look for the other things also here, like necrobiosis lipoidica diabeticorum, granuloma annulare, diabetic dermopathy, shin spots, especially over the feet and the legs, diabetic thick skin, diabetic hand syndrome, diabetic bullae. So bullae we often see in some of our patients. Okay. So again the thick skin is also possible. Shin spots is very common. Necrobiosis lipoidica diabeticorum and granuloma annulare in some cases. See, NLD is a rare complication usually seen in young adults, may precede the onset of the diabetes, may be the pre-diabetic marker. Earliest lesion, slightly elevated shiny papules, later round, oval or irregularly shaped plaques with well-defined borders. Form consistency with the glistening surface like tightly stretched cellophane or the glazed porcelain. Sometimes wrinkling gives the atrophic appearance. Central portion yellow or the sclerotic. Borders are elevated reddish, blue and peripheral. Female predominance 3:1. Any part of the lower legs and the shin is the commonest site. Occasionally over the thighs, arms, hands and abdomen or the back. May gradually fade or remain unchanged. Sometimes the secondary infection ulceration may also develop. See, this is the picture. Okay. So this is the silvery scales. You can appreciate more. Histological features: macrobiotic changes, foam cells, lipid cells, perivascular inflammatory infiltrates, obliterative lesions in the small blood vessels. Treatment of the NLD, no specific treatment. It's the intradermal steroid injections or the ointments. Surgical removal of the skin graft, pentoxifillin, and improved glycemic control has no influence on the course of the NLD. Improved glycemic control has no influence on the course of the NLD. So NLD will take its own course. So this is the granuloma annulare. It is a benign, asymptomatic, self-limiting. Classic form and the less common forms. Classic form is an annular or archiform lesions with the flesh colored papular border on the flat surface, flat center. Histology: focal degeneration of the collagen in the upper and the mid dermis. Histocytic palisaded arrangement around the collagen bundles. Abundant mucin. So this is the granuloma annulare on the knuckles, showing the ring forms. So this is the NLD. Okay. So please think of the NLD whenever you see such lesions. And this is the granuloma annulare on the knuckles. Diabetic dermopathy, also called as Melin spots, spotted leg syndrome, brown spots, shin spots, and pigmented pretibial patches. Small, dull red scaly papules. Latter characteristic multiple bilateral, circumscribed, round or oval, shallow pigmented scars on the pretibial areas. Found in adults, usually the duration of diabetes more than 10 to 15 years. Male is to female, 2 is to 1. Where NLD is female predominance. Here is the male predominance. Lesions generally tend to subside over 1 to 2 years. So this is the dermopathies, diabetic dermopathy. Scleroderma diabeticorum is a rare disorder, a diffuse symmetric induration and thickening of the skin of posterior neck and upper back, more extensive and involve the trunk, arms and the legs. Etiology not known. Invariably the patient is an adult with a long duration of the diabetes and spontaneous resolution is very rare. So we are interested in this case. Acanthosis nigricans, very common. It is a marker of insulin resistance and consequent hyperinsulinemia. It's due to the stimulation of IGF-1 receptors on keratinocytes by the insulin. Common sites, neck and axilla, may also be seen on the forehead, umbilicus, knuckles and groin. Partially improves with the regression of the hyperinsulinemia. Bulle, the asymptomatic blisters on the toes and the fingers. Recurrent. Etiology not known. Heal slowly without the scarring. Intraepidermal vesicles and mild inflammation. Proof of the large vesicles composed of the loose hyperkeratotic cells of the stratum corneum. Vesicles filled with the amorphous pale eosinophilic material. Sterile fluid. Contain the sterile fluids. See, these are the bulle. Foot bulle. Okay. So these are other sites. It must be drained to avoid the necrosis of the underlying tissue when it is a large. Small bulle may be left alone. Complications of the diabetes, neurovascular and ischemic skin changes of the foot ulcers. So far we discussed about the skin lesions in the diabetic individuals. Now the complications of your diabetes, complications of the diabetes. Distal gangrene, disordered sweating with autonomic neuropathy, increases susceptibility to the skin infections like bacterial boils, candidiasis, especially intertrigo, perineal infections, balanitis, fungal dermatosis. Autonomic neuropathy. Evidence of autonomic neuropathy is commonly manifested by disturbance of the sweating, usually anhidrosis of the feet. Patient complains of excessive sweating elsewhere. A compensatory mechanism for loss of the ability to regulate the temperature in the involved area. See the furuncles, multiple furuncles, furuncle in the forearm. Staph aureus is the most common cause. They are recurrent and multiple in diabetes. So the carbuncle is a very common in chronic diabetics and the nape of the neck and the posterior chest, paraspinal areas. Infection involving the several hair follicles with multiple openings discharging the pus. Staph aureus is the causative agent. Nape of the neck and back. Associated with the poor glycemic control. May be associated with a severe systemic upset, maybe sepsis. Needs a surgical drainage in most cases. So it's almost like a spotter for us. So with the multiple openings, so these are carbuncles. See the arteritis externa. Okay, some polyps. So big cellulitis. This cellulitis is associated with the deep vein thrombosis. See intertrigo. Oral candidiasis, very common. Chronic diabetics or HIV positive or chronic steroid therapy. So oral candidiasis are very common. See vulvovaginitis and balanitis. Sometimes they may be the presenting symptoms of the diabetes. Fungal infections. Okay. See the nice. It's a very difficult to control them. We have to use a very long duration of the antifungal agents here. Maybe 3 months, 6 months. Complications of the diabetes treatment. Maculopapular eruptions. Steven-Johnson syndrome for your sulfonylureas therapy. Purpura. Photosensitivity. Erythema nodosum. Porphyria cutanea tarda. Alcohol-induced flushing with chloropropamide. Now the chloropropamide is not being used. Localized allergy. Systemic allergy like urticaria, anaphylaxis. Lipoatrophy and lipohypertrophy with your insulin therapies. Idiosyncratic reactions like pigmentation and keloid formations. So these are all possible because of our medications we given to our diabetic individuals. Insulin allergy earlier is very common with your porcine insulins and the bovine insulins. Now with the human insulin, so these are not that common, but still some people they develop the insulin allergy. Insulin allergy in the thigh, local allergy to the insulins, extensive local allergy to the animal insulin. See sepsis at the site of the insulin injection, a lack of the hygiene. See the lipoatrophy, lipohypertrophy. Old or impure insulin preparations, now rare with our human insulins, due to improper injection technique and failure to rotate the injection sites. So some people they take the injection at the same site every day. So that leads to the hypertrophy. Now coming to the endocrine and other syndromes like glucagonoma. So that is migratory necrolytic erythema, Cushing's, so skin atrophy, striae, hirsutism, Cushing's facies, acromegaly, thickened skin, increased sweating, tall, partial and the total lipodystrophy, ataxia, telangiectasia, and the xanthomata. See the glucagonoma, a mild diabetes state, migratory necrolytic erythema, and the muscle wasting. Eruptoxanthomata, severe hyperlipemia leading to the milky plasma and lipemia retinalis. See xanthomata tendinosum, over the tendons, firm nodules attached to the extensor tendons, associated with the familiar hypercholesterolemia. So get the lipid profile here. See the tuberous xanthomata. These growths are located in the skin, not attached to the underlying tissues, unaffected by the insulin therapy. So in conclusion, all persons with the diabetes develop some skin manifestations of the diabetes at some point of the time. Maybe the cutaneous markers, maybe the diabetes and skin lesions, or maybe the complications of your diabetic treatment. Sometimes maybe because of the other endocrinopathies. Might be explained on the basis of the changes in the structure, function, and the color of the proteins. Skin findings, indicators of the patient's current and the past medical status, metabolic status. Some of the skin lesions are self-limiting. All infective lesions have to be aggressively treated based on the causative organisms and culture and sense. Mostly here the staph aureus, so you have to use the gram-positive antibiotics. Surgical intervention may be used whenever they indicated like a large bullae or necrobiosis or cellulitis. So here the debridement is needed. However, glycemic control should be the main focus. So that finishes skin and diabetes.